clinical talent that we have. So this specialization of mental health as it existed, and it's interesting because even in sort of general practice, people who sort of call themselves general practitioners, who might deliver babies and as well as treating infections and colds and things of that sort, they tended to stay away from not considering mental health to be part of their portfolio. And what's changed, in my opinion, is a couple of things. Number one is the need that's changed. There's a broad need for people to do mental health. We just need as many practitioners as we can get. So that's an important part of it. And the other thing that has changed is that mental health, psychiatry and mental health have become more scientific. Not in the sense that we have biological tests for psychiatry, which we still don't have, and we bewail that, but we have much more accurate questionnaires, which are our stethoscopes and our thermometers. We have much more accurate questionnaires and approaches and algorithms, which help people even who don't have expertise to be able to make these diagnoses. So that's a huge sea change from when I practiced, in which case we completely relied on, quote unquote, the expertise of the psychiatrist. And we took great pain in the notion that it was our clinical experience and clinical expertise that carried the day. But today we have a lot of techniques where these are much more portable and much more disseminable, are able to be disseminated to non-mental health experts. And that's a wonderful thing because we can now get mental health in the hands of far more practitioners. Moreover, these practitioners are much more likely to have the trust of their patients than psychiatric consultants. So wherever possible, I think it's very important as a first line, primary care clinicians do a good deal of the mental health. I'm happy to talk about that as a policy issue, as a philosophy issue during the question and answer period, but let's proceed here. So I've given a series of talks here, one on depression, one on anxiety, one on suicide, and this one is on psychosis and bipolar disorder. And I want to be clear, we're not expecting people to do the treatment of psychosis and bipolar disorder, but we want every primary care clinician, every nurse to be able to recognize this. I want to thank the REACH organization who have developed this training material. I've worked with them for 20 years, and they've trained over 5,000 primary care clinicians and continue to do that. And we're hoping to bring the full version of this training to Guyana in some point in the future. So what is psychosis? What's our goal here? Our goal is to be able to differentiate a difference among the different psychoses, primarily pediatrics, because these lectures are going to be primarily about pediatrics, but almost everything I say today will generalize because it's children and adolescents, and adolescents, 17, 18, 19-year-old adolescents are already quite adults. So most of this will apply to adults. We want to talk about the cognitive symptoms, psychosis, describe the treatment options, even though most of the time when it comes to psychosis, a mental health professional will be involved. The primary care clinician may manage it. In many systems, even in the United States, a psychiatrist may make the diagnosis and start the treatment, but that treatment might be continued and carried on by the primary care doc. So what is psychosis? It's severely disrupted thought and behavior, resulting in a loss of developmentally appropriate reality testing. Again, developmentally appropriate. So reality testing is there's different appropriate reality testing at different ages, what we would expect at different ages in development. And if you're not meeting that and you have trouble with reality testing, that's an overall concept of what psychosis is. We'll get into details in a moment. So it involves evidence of disrupted thinking on a mental status examination as well. So psychotic symptoms are very characteristic of schizophrenia, but they occur in other illnesses. So don't confuse the first lesson walking away from this. If you learn nothing else, I want you to know this. Don't confuse psychosis with schizophrenia. Schizophrenia is in 1% of the population, and it tends to be an illness that lasts a lifetime. And so, at least in the United States, for example, most psychiatric beds are occupied by people with schizophrenia because it's a lifelong illness, unlike depression, which is much more common, but these episodes are short-lived. So schizophrenia is out there. It's something people are aware of. So it's the most common type of psychotic illness that we're aware of. But don't confuse symptoms of psychosis with schizophrenia. Schizophrenia has multiple symptoms of psychosis as its main presenting things. But there are many other ways that psychosis, psychotic symptoms appear. And when I say psychosis, I mean psychotic symptoms. It can happen in mood disorders, in neurologic conditions, in intoxication. It can occur in many different things. Well, what is this psychosis? If it's not schizophrenia, Dr. Amsel, what is it? Okay. Well, I want to organize it in the following way. I want to think about normal behavior, and normal behavior involves reality testing. So it involves a stimulus response. What does that mean? I get a stimulus. I process that stimulus. I have a cognitive process, and then I respond. Okay, we think of stimulus response with nothing in between, but no, I get a stimulus. I do a cognitive process, and then I get a response. So Judith says to me, "Okay, let's start." I think about that. Okay, maybe we should get ready to start, and I start my talk. Let's go into greater detail. The stimulus comes in through sensations. So I need the whole.
There are more people arrived meanwhile. It's important to inform you that the room is getting really full. Can you show him that?
Terrific.
Yeah, that's maybe good for you to know that we have more nice audience.
Okay, fantastic. So if it's okay, if you just arrived, this is a good place to arrive because I'm going to give the definition of psychosis. So this is a good place to arrive. The other material is more introductory. So what is psychosis? Well, I want you to think of normal behavior. We have stimulus and response. We've all learned the stimulus response in greater detail. I have a stimulus. I have a cognitive processing of that stimulus, and then I respond in greater detail. There are sensations, and so for each of the sensations, I have a system. Visual system, the auditory system, the olfactory system. So I have a sensation. The sensation leads me to have experienced thoughts. I have thoughts about it, okay? I see someone on the street, I think I recognize him, then I say, oh, I think I recognize him, so I think about it. Those thoughts lead me to have beliefs. Oh, that's my old friend Joe. And then behavior. I will go approach Joe and say, oh, hello, I see you on the street. So each of these has a mental system in the sequence that it happens. Now, when we talk about psychosis, there are many different kinds of psychosis. And so one way to organize it, if I think of these 1, 2, 3, 4, these 4 steps, anytime I have a failure in one of these 4, each of these 4 steps, I can have psychosis in each of these 4 steps. For sensation, I can have a break with the normal function of sensations. And those are hallucinations, auditory, visual, tactile. Most common is auditory hallucinations. But that is a breakdown in the reality testing involving sensations. Well, what about thoughts? Well, I can have something called formal thought disorder, where I can't think logically, where my thoughts are tangential, and my thoughts and language are disturbed, so I can't think in an organized way. So that can be broken, and then that's the psychosis of thought. I also have a psychosis of beliefs, where the beliefs are wrong. So where do I have a thing with beliefs along? Those are delusions. I'm most commonly associated with paranoid delusions, but I can have other kinds of delusions as well, amorous, grandiose delusions. But that is a breakdown in the belief system. And then finally, the behavior system. I can have agitation, non-goal oriented things, catatonia. All of these are psychosis relevant to behavior. So when I think there seem to be a whole lot of different kinds of psychosis, think of these 4 parts of the normal behavior cycle: sensations, thoughts, beliefs, and behaviors. And think each one of these can be disrupted, and in each one of these, there can be a psychotic form of that. And then you'll understand the different types of psychosis that can exist. Okay, my slides jumped here. So I actually went through this already. I perceive, I reason, I believe, and I behave. And in normal life, I do these, and I can have breaks with any of these, which gives me psychosis. Okay. So what are the core cognitive symptoms of psychosis in children and in youth? Let's go this one by one. Remember, I can have thought distortion, breaks in the train of thought. So I have a private logic. It can be incoherent. It doesn't make sense. It's a thought disorder. Now, a thought disorder is a problem in the way that I think, whereas a delusion is the problem in what I think, in the belief system that I have. So this is called thought process, and this is called thought content. These are false beliefs that I have, okay? And in order to be a delusion, a belief has to be both false and fixed, which means I have this false thought that the FBI is following me around. And even though I could sit down, I call the head of the FBI, I talk to them, I say, it's not true. It won't make a difference, okay? Evidence will not change a delusion. And that's how I know it's a delusion. Because a person can have mistaken thoughts, mistaken beliefs, but if I show them evidence and they change their mind, it's not a delusion. Delusions are fixed and false. So I hope I hope that's clear. And there can be very strange behaviors, usually agitation or catatonia, which would be a behavior disruption. I can have hallucinations. Usually they're auditory, threatening voices, comments. I can also have visual hallucinations, but those are usually some brain disorder because of toxicology or something. Most commonly in schizophrenia or other kinds of psychiatric hallucinations, which are psychiatrically based, they are auditory hallucinations. Okay, so visual hallucinations are not as common. So what are the psychiatric, those other schizophrenia that can have psychotic symptoms? Well, we have schizoaffective disorder, which is a disorder that lies somewhere between mood disorders and schizophrenia. It's kind of a gray area between them. So you could have psychotic mood orders, especially bipolar disorder. So those are, the primary diagnosis is major depressive disorder, but I have major depressive disorder with psychotic features, or I have mania with psychotic features. So in those cases, the psychosis will go away when the mood disorder goes away. So a person can have a severe depressive episode, and during that severe depressive episode, they can have hallucinations and delusions. But when that mood episode lifts, when I treat the mood and the mood episode lifts, the psychotic symptoms will go away. If they don't go away, then I'm not dealing with a mood disorder, then it's really schizophrenia or schizoaffective disorder. But in mood disorders, so it's a great relief sometimes when someone comes in the hospital and they have a psychotic symptomatology, but I realize that they also have a mood disorder. Then I say, okay, maybe this is not going to be a permanent state of psychosis. If I treat the mood disorder, it'll go away. And indeed, if that happens, then I can be assured that that was a psychotic depression, but not a primary psychotic disorder. It's not going to last forever. It will go away. With PTSD and abused youth, they're sometimes vulnerable to have brief psychotic symptoms. Don't confuse flashbacks with hallucinations. Flashbacks are really just memories. They're not like that. But severe PTSD in abused youth can show brief psychotic symptoms as well. There are medical causes of psychosis, as I mentioned. And so in other words, in people who do not have schizophrenia, but they show up and they seem to have psychotic symptoms, what should I think? First thing you should think is whether there's a medical cause, CNS infection, delirium, neoplasia, endocrine disorders. There are some genetic symptoms, autoimmune disorders, toxins, okay? When people ingest toxins, they can give you psychotic symptoms because they act directly on the brain to distort one of those systems, the sensation system, one of the sensation systems or the thought system. So there are medical causes of psychosis. There are also substances that can cause psychosis, okay? LSD, hallucinogenic mushrooms, okay? Steroids can cause, in high doses, steroids can cause psychosis, as can anesthesia. Very high dose of anticholinergics can. And acute psychosis due to intoxication usually remits within days. So if I can get the toxin out of your body, it usually clears. Although it's sometimes confusing because sometimes schizophrenia first presents when a person ingests substances. People who actually have schizophrenia, but it hasn't pronounced, it hasn't shown itself. Sometimes the way it first shows itself is after they've used the substance. So you're going to have to sort that out, the difference between the substance causing the psychosis and somebody who actually has psychosis, but it only came out because of the substance use. But again, that is not a primary care function, is to sort that. That's a subtle, difficult thing to sort out that we want you to know about. But this is a case where something as severe and serious as that does involve. This is some place where I say, no, primary care should not be the primary people taking care of something like that, like a new onset psychosis, but we very much want you to be aware of it. What's the epidemiology? Children under 12 years old, schizophrenia is extremely rare. In adolescents, schizophrenia is maybe 0.5%. In adults, schizophrenia is about 1% of the population. Now, there are some things that are normal, and they may seem psychotic, but they're not, especially in kids. So illusions or sounds or visualizations that are misinterpreted. So you wake up in the middle of the night and you see this, the horse in the room. You say, my God, there's a horse in the room. But no, it's not the horse in the room. It's that in the shadows, the pillows or the quilt is laying in a chair, and it's the way it's folded up is it gives you the impression of a horse, and for a second you might think you see a horse. So those are called illusions, i.e., you see something, but you misinterpret it. Unlike a hallucination where there's no actual stimulus, your brain is making up the whole stimulus. In an illusion, there's some stimulus that because it's dark or you're tired or some reason, the stimulus gets misinterpreted. So that's an illusion. Voices, a single voice saying to the child, oh, you're bad, or saying one or two words or calling a child's voice. That is not a psychotic symptom. That happens. Imaginary friends, in general speaking, imaginary friends are make-believe, and kids know that they're make-believe, and they're normal. And if you ask kids if they're real, they can tell the difference between their real and their imaginary friends. And that's true also for fantasy in general. In young people, we want young people to be fantasizing and think about things. But if they can, kids can get very involved in this, and they can, the fantasies can come to be somewhat real. But in the end, the kid will be able to tell you the difference between, is this make-believe or is this real? So those things, don't worry about them. They're not psychotic symptoms. They're normal developmental issues. Well, as I said in many of my other talks, when you're talking to children or adolescents, and you're talking to them about some difficult mental experiences, which might feel shaming to them, you have to find ways to speak to them. And again, one of the ways that we talked about in my previous talks is this notion of normalization, that you embed in your question the information that, hey, I'm a doctor and other people have told me about this. I'm aware that this happens to people. So you want to embed this in your question. That gives the patient the feeling that they're not strange, the feeling that you are aware of these things, the feeling that other kids have it. And it's very simple. You say, lots of times kids tell me that they hear or see weird things. Is that happening to you? Okay. So you let them know that other kids have had this. Once you've sort of opened up the door to that, then you can ask them questions like, does your mind ever play tricks on you like that? Do you hear voices talking to you and nobody else is there? Or does your mind ever feel confused? These are questions kids will understand. And again, I would preface all these by saying, other kids have told me about this. What about you? So kids can describe their psychotic symptoms. But other times, most of the time they can, but some of the times they're too disorganized and they're too affected by it to be able to communicate. So then parents and family members, obviously you want to get them in for taking a history and seeing what they have seen. So how do you evaluate psychosis if it walks into your office? Okay, you want to think about what the core systems are, how much it's impairing their functioning. You want to rule out drug toxicity by doing a drug toxicity screen, rule out any kind of CNS lesion. In many of these cases, if someone comes in, they have a serious psychosis and you can't pin down what's going on, we do recommend that you do brain imaging if nothing else, is explaining why this new psychosis and other medical conditions that could be involved in that. What about treating an acute psychosis? Well, we recommend that certainly for a first-time psychosis in a child or adolescent, that you do send them to an emergency room. So again, we're talking about the things that we think primary care can do and can't do. First-time psychosis, we do think it requires emergency room or a psychiatric consultation, because these could be very dangerous situations. If a child suddenly feels that they're being injured, it's unpredictable what their behavior will be in response to these psychotic symptoms. I had a kid referred to me and everyone said he had OCD, and I asked him what the problem was. And after a while, he told me that he believes, very seriously believed, that people were chasing him around and they had HIV-infected needles, and they were trying to inject him with these HIV-infected needles. This was a 15-year-old young person who had been fine months earlier, but developed this very severe paranoid delusion that people were chasing him around with HIV needles. And he said he had he didn't call them hallucinations, but he could somehow hear them threatening him. Well, that's very dangerous. You have no idea how this child is going to react to that. That's a terrifying situation. So you have no idea. That child belonged immediately. I said, this is not an OCD. This child belongs in an emergency room, because he probably needs hospitalization to try and stabilize him. But his behavior in response to this can be completely unpredictable, and I was afraid of leaving him out there. For the younger kids, these are the FDA-approved drugs for schizophrenia: Abilify, Risperdal, Zyprexa, and Seroquel. But again, when you see psychosis, don't assume it's schizophrenia. See if it's one of these reversible toxic things first, and then it'll resolve. But if it doesn't, then it turns out to be schizophrenia. These do have FDA approval for schizophrenia. What about emergency medicines? Olanzapine orally disintegrating tabs is often used. Risperdal tabs or ziprasidone tabs. These are tablets that are very, very rapidly disintegrating. So if there's an emergency kind of psychosis, a child is very agitated and they're losing control, these are the medications you would introduce. This chart shows you a safety and tolerability of the antipsychotics, or what's called the atypical antipsychotics. The reason they're called atypical is because there was once a different set. When I started training, we used Haldol and Thorazine, and those were called the typicals. And then these newer agents came in and they got the name atypical, but it makes no sense because they're now typical, right? So nobody calls the newer generation of antibiotics atypical antibiotics. They're just the newer antibiotics. So when they say atypical psychotics, just think, those are the new antipsychotics that are being used currently. And you can see that one of the major problems to worry about with kids on these is weight gain. And oftentimes, when an adolescent is having a psychosis, which needs to be on these medications, that is one of the big side effects you have to anticipate. And we recommend that before starting somebody, if at all possible, you get a nutrition consult. So you get them involved with a nutritionist so that they can control their weight, because they do have a tendency of gaining weight. And neither the young men nor the young women like this. And young women especially can be very sensitive to weight gain and stop the medications because of that. So it's a good idea to put in preventive measures of helping them not gain that weight. So that's when you have an acute situation, a new situation of an onset. But what about the long term? So chronic schizophrenic patients may very well have gotten their treatment initiated, gotten into a routine with their medications, which they're going to stay on for a long time. And you, as the primary care clinician, primary care nurse, may be asked to follow them and to continue them on those medications, even if you wouldn't be involved necessarily in the initial evaluation. So here is one of the things you need to do when the you are monitoring somebody on those medications over a long period of time, these are the kinds of monitoring that you want to do. Lifestyle, height and weight, sexual symptoms, check them for akathisia, which is a movement disorder of blood pressure, glucose, because again, over time you could get problems with weight and also problems with metabolic situations. Okay. Now I'm aware of time. We started a little bit late, so I'm going to take a few minutes to talk about bipolar disorder. And I just want to make the main point is that bipolar disorder is much more rare than depression. But unfortunately, in the last number of years, there's been a 40-fold increase in the number of people who have a diagnosis of bipolar. I tell my residents, if they open a chart, and this is in America, if you open a chart and a chart says that the person has bipolar disorder, that you've got to double check that. You've got to make sure, because the diagnosis over the last many years was given out very, very freely and loosely, and that was not carefully assessed. There are multiple reasons we can talk about that, but what is, sorry for the jumping slides. So there's been a huge increase. I would tell people that when you hear a bipolar disorder diagnosis, make sure you could verify it, because there's a lot of people who have this diagnosis but not really deserve the diagnosis, because a bipolar disorder involves a manic episode, okay? And a manic episode, as we'll see, is a distinct period. So it's not that a person has always had behavioral problems. If a person has always had behavioral problems, as a child, we would call them oppositional defiant. They have other diagnoses, but not bipolar disorder. So bipolar disorder is not a fluctuation of mood that's always gone on, or a kid who has also always been irritable. It is a distinct period, a change from a baseline. A person who has a particular baseline that's fine, it's normal baseline, and then they go into a manic episode. And here are a way of thinking of them. Hypers is a good mnemonic for it. Hyperactivity, irritability. Sometimes there's psychosis, not always. It tends to be grandiosity. Okay, kids feel it's the opposite of depression, where you feel very bad about yourself. You tend to have overestimated thoughts about your abilities and how important you are. Your mood can be elative and expansive. Your thoughts can be very fast. People talk very fast. And one of the things you see about bipolar disorder, they talk extremely quickly, like that. They talk extremely quickly because their thoughts are racing, okay? And also, they can't sleep. Well, it's not like depression. In depression, you can't sleep. In depression, people have insomnia. They're desperate to sleep, but they can't fall asleep, and they're tired. In manic episode, there's a lack of need for a sleep. People don't sleep for a week and they're not tired at all, right? So it's a high energy state. It's not insomnia. It's no sleeping because they don't need sleep. Let us quickly look at this case. Age 10, Nicola had a brief depression, but it resolved. She's 14 years old now. Several weeks, she had a personality change. She's wearing sexy clothes, which she never did before. She's stopping strangers on the street and talking to them. She's up all night. The mood goes from laughing to irritability, and she's hardly getting any sleep. So this is a classic case, okay? She's hardly getting any sleep. This would be a classic case because it's a distinct episode, changed behavior. It has the DSM criteria for bipolar disorder. Notice the mood, the sleep, the grandiosity, the familiarity with other people, which is an increase in goal-directed activities. Therefore, this is, and she has a history of depressive disorder, so this is a classic case of bipolar disorder, okay? So one of the things that can be confusing, and one of the reasons that bipolar disorder is overdiagnosed, is because this notion of irritability, just irritability by itself without the other symptoms, can occur in so many different things. So irritability alone should not jump to the conclusion of bipolar disorder. It could be any of these things in this list. And also attention deficit disorder can get confused with mania. Why? Because again, you can have this hyperactivity going on, but again, it's not a change from baseline. It's not a change from baseline. It's what they always were, but it can look like it can be confused with bipolar incorrectly. So make sure to distinguish distinguish those two things. Now, again, the reason we're giving these talks to this particular talk to primary care clinicians is not because we feel primary care clinicians should manage mania. We want you to be able to recognize it, but it's really going to be managed by a mental health care professional. That this is the kind of thing you do refer out. We recommend you treat depression, treat anxiety in your own office, screen for suicide. But when it comes to something like psychosis or mania, that is something you are going to refer out. So it's not something you're going to treat in the office, just to be clear on that. And so there are a number of slides on what the treatments are. But again, I don't think that I'm going to, in the interest of time, and I know the next talk also deserves their time. So I'll just let you know that the most important thing for you is to know about how to recognize it. And in terms of what the treatments are, I think we're going to skip that for today. And again, out of respect for the next speaker. So the summary for you is bipolar disorder. It says it's difficult to diagnose, which means it can be difficult to diagnose unless you pay attention to a full-blown manic episode, which has not just irritability, but all of the symptoms. And you see all of those symptoms: irritability, grandiosity, no sleeping, all of those kinds of symptoms, and it's a change from the past. And when you see that, it's quite dramatic, and you'll know that you're dealing with psychosis. So I hope it has been helpful on this particular talk to let you know about some of the more severe psychiatric symptoms that may present. Again, both of these are relatively rare. 0.5% for children and adolescents are going to show up with schizophrenia. About less than 1% is going to show up with bipolar disorder. But I hope that this has helped you recognize when they're there. And your treatment is going to be done by consulting a mental health professional who'll be involved with you and actually make the first treatment recommendations. And then you might manage it after that. I think we could take one or two quick questions, and then I will turn over the dais to the next talk.
Thank you very much for your very important, very comprehensive lecture. And really, we have time for questions. So I would like to give the floor to the audience. Could you please always show me the camera, the person who is asking? Thank you very much. Because then the person can follow better. Yeah, thank you. So we have the first question. Yes.
Okay. Professor, my name is Stanton Pitchlow. I was diagnosed with bipolar 1 20 years ago. I had several manic episodes that needed hospitalization. I am currently on, I've used different treatment plans, which include antipsychotic and mood stabilizers like lithium, tegretol, olazapine, haloperidol, and risperidone. I've had periods of probably 8 years. The longest period without having an episode was like 8 years. My question to you is it possible for me to have longer periods of wellness and not experience an episode?
Yes, it is. It is definitely possible. And what we believe is that if you work with your clinicians and they sort of maximize your treatment, make sure that you're not being overdosed or underdosed, and you have the right level of treatment, and try to manage that. Try to reducing stress in a person's life can also keep them from going back into an episode. But unfortunately, I can't give you a better answer because individuals are very, very, very variable in this. But if you manage the good treatment, it's definitely possible for people to go for long periods of time. And as people get older, we see that people can go for decades without having an episode. So I wish you best fortune in that.
Okay, can I add to that, please? I'm very much aware of all of the symptoms, and I'm also aware of my triggers, and that is what I keep in check, seeing if I'm experiencing any of the symptoms, and also being aware of what can trigger me, like loneliness, fear, and grief.
Yes, so that's fantastic that you are aware of those kinds of things, and you are clearly a person who is very articulate and intelligent in talking about this. And I would encourage you to be a patient advocate and an educator for other people who are going through this, because you're clearly very articulate and very aware of it, and you would be an absolutely excellent ambassador to other people who are going through this experience for the first time and somewhat confused by what they're going through. So I don't want to burden you with a task, but I do want to say that just for meeting you, I could see you would make an excellent patient advocate and ambassador. So good luck to you.
Thank you. Thank you.
Thank you very much. I would like to ask the audience if you have question from somebody. We get very important practical information as well. So, no? Have the last opportunity now, no, maybe not the last, but now in this. So, and then we go on, and yes, see, that is with us. Our next presenter, it's my pleasure to introduce you Dr. Moderator, who is an associate professor of medicine of Florida State University, medical director of Midway Research Center, founder of Midway Specialty Care Center, Florida, US. With over 22 years of experience, Dr. Gopal is certified by the American Board of Medicine and Infectious Disease. He served as a principal investigator for clinical research and has conducted over 300 clinical trials at immunology and research center. Simultaneously, as a philanthropist, his organization has treated over several hundred uninsured IgE and hepatitis C patients. Through Midway Specialist Care Center, Dr. Ronkova and his team members the initiative of ending the HIV and the hypertension pandemic by 2030 in critical communities throughout Florida and have obtained their doors to Guyana, where new opportunities are available to the community. Yeah, great. So it's really great that you are with us. Thank you very much. And I give you the floor to have your presentation now. Thank you very much.
Thank you, and thank you very much for that introduction, and thank you everyone for attending the session. So unfortunately, I wish I could be in Guyana. I was there last year for the first meeting, and this year surely missed out being there. And next year, I'm definitely going to try to make an effort. So our presentation is going to be about looking at our HIV population mental health. Mental health has been such an integral part of what we do every day. And I think it is important to understand how it relates even in the world of infectious disease, even in the world of infectious disease patients. We see it from day one, but we don't try to identify or manage it very early. We tend to wait too late sometimes. I'm going to ask my associate, Ms. Cassandra Petit. She'll present our abstract, which we've been reviewing recently. But I want to take away messages to think about this abstract in the context of Guyana, in the context of HIV, in the context of comorbidities, in the context of other challenging disease states that we look at. And it could be all tied in or related. Even though we look at mental health and HIV, it could be looked at in diabetes. It could be looked at under challenging long-term complications of other disease states. I present to you, Cassandra. Go ahead.
Yes. Good afternoon, everybody. My name is Cassandra Petit. I will be sharing my screen. So what we will be going over in this abstract is the racial association of viral suppression and mental health diagnosis amongst patients living with HIV. So as we look at the background of this abstract, we see that about 63% of people living with HIV in the United States have a mental health diagnosis. The prevalence of depression amongst people living with HIV is as high as 39% compared to about 20% of the general population. And the prevalence of anxiety is as high as 19% compared to about 2% of the general population. And then when we look at a mental health diagnosis, it is often associated with poorer health outcomes for people living with HIV, including decreased rates of viral suppression. And in 2020, only 69% of people living with HIV were virally suppressed in the state of Florida, with reports of higher rates of viral suppressions amongst white, non-Hispanics compared to Hispanics and Blacks, again, in the state of Florida. So our objective today is to look at 2020 viral suppression rates of people living with HIV and do a descriptive comparative look at the data of Midway Specialty Care's data and compared to the state of Florida, and then looking into that subset of individuals that have a dual diagnosis of HIV and mental health of depression and anxiety, and determine the mental health impact on viral suppression on our sample population at Midway, and report viral suppression rates by age and race within that mental health population. So materials and methods. When we compared viral suppression rates at Midway sample population of mental health by race and mental health diagnosis, specifically anxiety and depression, that population sample was filtered by their diagnosis of HIV and having either a singular or dual diagnosis of anxiety and or depression. The population demographic was extracted via our electronic medical records by race, ethnicity, and age. Viral suppression during this abstract was defined as a HIV viral load of less than 200 copies. And we will also be looking at those that have an undetectable viral load that is less than 20 copies as well. So our results. Within the Midway specialty care client population, about 3,502 patients were identified of living with HIV and having a viral load within the last 2 years. And within that population, 828 patients were identified to have a diagnosis of depression and or anxiety. And within that sample population of 828 patients, about 373 patients were white, 228 patients were Black, 138 patients were Hispanic, and 92 were considered other. And within that, we had 221 females and 606 males. The median age of the sample population was 53 years old, with as young as 18 to 85 years. About 7% of that patient population was not virally suppressed. So they had copies, they had HIV viral load copies above 200 copies per milliliter, which is, when compared to the state of Florida, it is much less, where the state of Florida was at 31%. Our sample population, Blacks were less virally suppressed compared to our Hispanic and whites, with Blacks of viral suppression rate being 90%, Hispanics being 94%, and whites being 95%. Our suppression rates were comparable when we looked at just their mental health diagnosis, with anxiety having a viral suppression rate of 95%, depression 93%, and anxiety and depression, the dual diagnosis, was at 92%. Among the sample population, about 94% were virally suppressed, with 83% of that population being undetectable. When you look at the state of Florida data, only 69% of their population is virally suppressed. So this is a graph that looks at and compares Florida to Midway's total population, and then the sample population that has living with HIV and a dual diagnosis of mental health. The green identifies the population that is not virally suppressed, where their viral load copies is above 200. And the blue is those that are virally suppressed with a copy that is less than 200. So as you can see, in the state of Florida, there is 117,477 individuals living with HIV. And only 69% of that population is virally suppressed. When we go over into the Midway population of the 3,502 patients, 93% of that population is virally suppressed of those that have an HIV diagnosis. And when we look into that sample population of 828 individuals that have HIV and diagnosed with anxiety and depression, the rate of viral suppression is the same, where 93% of that population is virally suppressed. As we remember in the background, oftentimes we see that viral suppression is lower when we look at individuals that have mental health. And that was not seen in the Midway population. When we look at viral suppression by age at Midway Specialty Care, we see that from those that were age 18 to 24, 10% of that population was not virally suppressed. For 25 to 34, about 16% of that population was not virally suppressed. 35 to 49 is 8%, and 50 plus is 5%. And that is significant looking at the 50 plus population, because of the largest population that we have in age demographic within Midway is 50 plus. So most of our population falls under that 50 plus population, and they actually have the highest rate of viral suppression. where their viral suppression rates are 95. And as you can see in this data set, we do see two distinct blue lines, and blue represents those that are virally suppressed. But the darker blue within this graph indicates within the viral suppression groups, those that are also undetectable, with their viral load being less than 20 copies. So as you can see that within Midway's sample population of the 828 patients, most of the virally suppressed patients across all age groups are also undetectable, with 60% of the population from 18 to 24 being undetectable, 69% from 25 to 34, 76% from 35 to 49, and 80% of the 50 plus population being undetectable. When we look at the racial demographic of Midway Specialty Care sample population of the 828, we see that 28% of the population group is Black, 16% are Hispanic, 45% are white, and 11% other. And when we look at Florida's patients living with HIV as a whole, the white and Black populations are actually inverted. There's a much larger Black population, about 45%, Hispanic being 25%, white being 28%, and other being 2%. And when we look within that sample population at Midway, again, that has a dual diagnosis of HIV and the mental health, we see that within the Black population, about 10% are not virally suppressed, right? They have a detectable viral load. In Hispanics, we have a 7% that are detectable, whites that are 5%, and other that are 5%. So within the sample population, we do see that African Americans have a lower rate of viral suppression compared to the other demographics, but all are still under 10%. And again, when we look at those racial demographics and looking at those that are undetectable across all populations, the rates of undetectable for those populations are above 70%. So most of those that are virally suppressed are also undetectable across all racial demographics at Midway. And when we look at viral suppression by mental health diagnosis, we see that all three are comparable, where those that were that have been identified of having anxiety, depression, and the dual diagnosis of anxiety and depression all are below 10% in the aspect of having a detectable viral load. And all in when we look at the those that are undetectable for all three, we see that 81% are on anxiety, 75% in depression, and 77% in being dual diagnosed of being undetectable as well. So conclusion, virologic suppression of people living with HIV at Midway Specialty Care Center was 93% compared to the state of Florida that had a viral suppression rate of 69%. At Midway Specialty Care, the age group of 25 to 34 showed less viral suppression of 16% compared to the other age groups that were less than 10. And in the mental health population, African Americans, Blacks, had a lower rate of viral suppression at 90% compared to whites and Hispanics, where whites were 95 and Hispanics were 94. At Midway Specialty Care, mental health diagnosis was not a barrier for lower viral suppression rates, where anxiety was at 95%, depression at 93%, and anxiety and depression at 92%. Looking forward and connecting this data that we have, that we've been looking at within our health network and connecting it to Guyana, our goal would be to have the ability to gather this mental health data for people living with HIV in Guyana through the use of an electronic health record. and to integrate the methods that are used at Midway Specialty Care Center, Florida, into Midway Specialty Care Guyana to achieve higher rates of viral suppression by utilizing methods of like educating providers about the need to integrate mental health practices within infectious disease like HIV care, because we see that within Midway that we have the ability that their mental health is not a barrier to having high rates of viral suppressions within this demographic group. Thank you. Is there any questions?
So thank you very much. And yeah, for the excellent presentation. And I would like now to turn to the audience and ask if you have a question to this extra important topic.
Excuse me, I just walked in right towards, no, you don't need to do that. I just walked in towards the end of your presentation where you're showing that graph. And I heard you talk about lower prevalence of lower viral load, being black people or black men. Did you account for race as a factor in that? And second, when we talk about mental illness, are you also accounting for shame and stigma surrounding both the dual connection between mental health and HIV within a Guyanese context?
Yeah, so those are really, really two good questions. So the first question, let's take the second question first with mental health and stigma. So the mental health and stigma, I see patients in Guyana and I'm aware of the stigma in Guyana. And it's the same stigma we face in the United States as well. And the stigma varies there's racial differences in stigma as well. We see a difference between the Latino group, between the Black group and the white group in the US. And there's also going to be racial stigmas being well described in multiple studies previously. So yes, it is an ongoing issue. And I think the first intervention in seeing a patient, that has to be addressed. Not to wait for a patient to fail their HIV treatment a year later to address mental health. On day one, we address stigma, we address issues, what the challenges and the barriers to treatment, the challenge and barriers to understanding the treatment, the fear of the treatment. So that's, even though we look at anxiety as a whole, anxiety includes several parameters like fear, issues with food inadequacies and other challenges we face in the US. And I'm pretty sure a lot of those challenges are in Guyana as well. But we don't have the data in Guyana in time. We'll have to get that data. And the strategy would be to have EHRs or have chart-based reviews to evaluate those strategies. So I think it's very important. So when we look at the state of Florida and we look at in the US and we see the high prevalence of Blacks in the communities and the lower incidence of viral load suppression across Florida, what Midway has done is quite unique. As an organization, we work in inner cities, we work in areas where there's a disparity in care. So we have a clinics in West Palm Beach, we have a clinic in Fort Lauderdale, we have a clinic in Fort Pierce, and these are really tough clinics with tough cities. So when we look at our viral suppression rate across our organization, and it's much higher than the Florida viral rate suppression, and there's many reasons for that, because we have an integrative approach. We address mental health from very early. We have nutritional services, we have transportation. We look at the patient as a whole, not just here's HIV, here's your viral load, here's a treatment, let's just treat that and then everything else will fall into place. No, we try to address mental health very, very early. I've been doing this now for over 20 years and almost 30 years now. And I've recognized mental health in disease state is such an incredible it's just an important part of treating patients and is not fully accepted and understood by lots of providers. So when we look at the success of Midway across with our statistical numbers, it is because we have that implementation strategy from very early.
Dr. Amsel, I know that you are familiar with the Guyanese context in terms of treating HIV. I suppose you know that when patients go to the center, they also have the option of seeing a counselor, okay? Sometimes they would opt to go see the counselor voluntarily, or the physician would refer them to the counselor either before or after the treatment session. There are also support groups among patients at the different sites, or at least they used to have before COVID. Good. And support groups, they're supposed to help each other, talk about their issues, etc. So how do you see mental health support being integrated into the clinics in Guyana? HIV.
Yes, I think, and again, that's another important and important question, and very interesting, because historically, when I went for my fellowship and went into infectious disease, we had this pathway of counselors, and we had this pathway of group sessions and stuff. And even in this room I'm sitting in right now, years ago we used to have this room here as for advocacy and for positive patients to come and sit and discuss that. But I found that that is not very successful. I found in my career that the patient or the nurse practitioner interaction with the patient, medical assistant, the caseworker assistant, not having truly a dedicated person, but integrating it into the care by the provider, by the physician, by the provider, into that person. I think it's well accepted by the patient more. It takes an extra 15 to 20 minutes of my time every single time. I'll give you an example. I walked into the room one day to see this 21-year-old girl, African-American girl. So I said, you look quite sad. What's happening? And, tell me about your story. And I went into her life and she started to cry, tears. She's been positive for 7 years. No one has asked her that question. This is the first time I'm seeing her. No one has asked her that question. And she got, she developed HIV after she was raped and abused. And for 7 years, every single day she considered taking her life. And she went to counselor. She's never discussed any of these things. I think the best approach to mental health with HIV or a lot of disease states is by the physician or by the provider. The other parts will help over time. They will add to the situation. A physician needs to understand anxiety. They need to understand the treatment of anxiety. They need to understand depression, the treatment of depression, short-term, long-term. And then there are complex cases, of course, where you will need the help of the counselor. You will need the help of the psychiatrist or the therapist. But those, in my opinion, for the last 20 years of doing this, are small numbers. If you do this right as a physician, and if you do this right as a provider, and even as a whole clinic model, my front office, everyone in my organization are fully aware, desensitized, aware of a patient coming in. I just got a patient texted me 2 days ago. She's incredibly depressed. She's pregnant. She's saying, I want to take my life. These are patients who you need immediate intervention. You bring patients into the clinic, you have these discussions, and you have, you have to develop trust. The key word is trust. Patients trust you, they will follow you, and they will listen to your guidance and advice. And trust is not by sending the patient to a mental health counselor. Trust is not by sending a patient to a support group. Trust is by you spending the time as a physician or a clinician and engaging that patient and understanding their social needs, the stigma, the challenges they're facing in their home and their situation. That's what trust is about. And with that trust, you can now engage with mental health.